So we have Sachu with us, and I think her talk, all of us are waiting for her talk, because she's going to be the practical person who deals with these children every day in and out, and she has made a lot of policy decisions. In fact, she was a pioneer of starting integrated education in Delhi. She helped us to get the children with CVI and with other problems into normal schools. So I am totally her fan. So I'm sure all of you will become a fan once you hear her.
Thank you so much, Dr. Suma. It is wonderful to see so many of you here in the morning for a topic like CVI. We really were wondering would we have audience, and I'm really very grateful that you all turned up. I'm going to talk about two things. One is early intervention, and one is how do we improve the quality of life of people with CVI after the dust settles. Early intervention, you all are great players in terms of early intervention, but when I talk about CVI, we not only need to look at the functional vision and the improvement of the functional vision and the visual latency and improving the visual maturation, but it is a hand and glove conspiracy that we need to have with many professionals, including other disciplinaries such as occupational therapists, speech therapists, developmental therapists, physiotherapists, and vision rehabilitation professionals, because we'll have to improve upon simultaneously the developmental delays, physical, and also the visual aspects. So, what are we really trying to work upon? All of these areas simultaneously, and year 1 is very critical, because year 1.5 to 4.5 is critical for language development, and year 1 to 6 is very critical for visual development, and we do not want to miss our bus when it comes to the physical developments, including the fine motor and the gross motor functions. So we have lots of things to do. So we have to look at the developmental delays. Even if you are you are a pediatric ophthalmologist, and you are actually the only sect of people who are tuned into CVI, and you know it is a global impact story. So even if you're not the direct person who is going to implement the matching up and bringing the child up to the developmental delays, that happens just not physical, but it's also, as you see, social, communicational, adaptive, language development. You are the key person who is at least going to direct the parent to the right person. That's why I used to tell Dr. Suma, why are we chasing our parents from morning 8 to 8 in the night from one corner of the city? If city of Delhi was circular, but in Bombay it is worse. If I have to go from one end of Bombay to the other end, it takes me 3 hours. And imagine the plight of our parents. Do we have services under one roof? No. And do hospitals have to have services under one roof? Yes, you need to stretch out. Apart from just having a vision rehabilitation center, if you can have at least visiting occupational therapists, physiotherapists, speech therapists, neonatal developmentalists, you are adding to the quality of life of children with cerebral CVI. And you are also required to have a developmental approach to when you are working. I'm sure you're all going to track your children up to 18 years of age. And by that time, you are going to play a role in educational, vocational orientation, and also what skills the child is going to develop. Now let's focus on vision, because we are very interested in the functional vision here. And we are going to, with CVI, work on the functional vision. I have worked with children as early as 1.5. And why? Because it's at 1 month that we expect that the child is going to have around 0.5 meter of vision. And I want to catch up on the developmental curve. And it's around 3 months that we all saw why children are very attracted to the color red. Because it's around 3 months that attraction to or the perception of color red is going to start, and from there on up to 5 months the primary color perception is happening. And because of the delayed visual maturation that we all anticipate with CVI, if we start visual enhancement therapy parallel to all the medical funda that's happening, we are improving the ability of the brain to build neural pathways and catch up with better visual outcomes. So we need to work on the vision skills. These are skills that are with all of us, and these unfortunately follow a hierarchical system of development. And you know that if fixation doesn't happen, fusion doesn't happen, and then further tracking, scanning is already talked upon as an issue with children with CVI. So we need to work on that. So we have till now heard what's the problem. Now, what should you as professionals track of the vision rehabilitation professional who is working is that are we improving on these vision skills, because these are hierarchical. After scanning, tracking happens, we need to see whether discrimination, figure ground perception, visual closure, visual memory, ocular permanency, ocular consistency, and eye-hand coordination, which is almost the 14th skill, and then comes face recognition. So for a parent, these are also tangible things that you can point out that listen, the therapy is working. Because from fixation, at least now your child has come to discrimination. Of course, she talked about the CVI range, but if that is not understood by parents, this is a simpler language that you can use. Now, there are 3 aspects that work with CVI children. One is vision stimulation, and the second is the visual efficiency therapy, which very few people stand and talk about, and I think I may be the one lone voice in the whole country talking about it. And after the visual efficiency therapy is also given, we need to make the child apply what they have learned in our clinical settings or in our centers to real life situations. So the first year of the child's life is just not the medical aspect, but I always say let surgeries happen, let medications happen, let imaging happen, but also it is about counseling the parents, it's about having a multidisciplinary approach, it's about starting therapies early. And because of the visual impairment, there are many other aspects that get impacted, such as picture perception, spatial orientation and perception, balance. Did we ever talk about balance since morning? No. Did we think that it also affects balance? Yes, it does. And bonding and building warmth. So all of this is what we look at when we want to do vision rehabilitation to improve as much as possible the quality of life, and primary aim is to get the child into a educational stream. And I would say it has around 6 to 7 primary components. One is visual improvement, as I said. So if a child is not fixating, then we start with a object that is very colorful with muted diffused light as much as possible to work on fixation. That is the first bit. The second bit is work on building, scanning and tracking. These 2 skills are very important. After that is a little achieved, then move on to helping the child discriminate. This is where concept development also needs to work upon. Discriminate between odd man out, or various shapes and heights, etc. So within that, as there are tinier movements or tinier fine gradations that have to happen in perception. Say for example, differentiating between a fork and a spoon, or seeing the action of the wheel moving in a car. We usually push a car and we expect the child to track. But does the child know that there is a wheel movement happening? Is there an understanding of being able to perceive between part to whole and whole to part? So when all these is worked upon is when you can come to working on recognition of symbols, patterns, alphabets, numbers, words, multiple words, making sentences. So this is what needs to happen when you want as a prior preparation for children to go into mainstream schools. As I said, the point number 2, the physical milestone delays. Right from 4 months or 3 months, we need to track the physical developmental milestones of gross motor and fine motor and work upon them if we find there is a delay. The second important or the third important aspect that we need to work upon right from age 1. Have you ever heard someone saying age 1 for concept development? Yes, please record it. It is age 1 that you need to start working on concept development. So I'm not going into much details, but at least the message that I want to give is ask special educators, ask therapists to work upon concept development from age 1. Moving from tangible to abstract. There are various ways to work with concept development. These are small items which you can purposefully have in your clinics, which later on help with the work of concept development. Writing skills is very important, without which getting your child mainstreamed into schools is going to be a challenge. You would see in this child how close the child is holding and writing. Of course, a posture correction is required here in terms of providing a reading stand. But the point is, it doesn't matter whether the child is going to read with 3 centimeters, 2 centimeters, 5 centimeters. It doesn't matter. Today I am associate vice president of a leading corporate that takes care of almost 31 schools, and I manage 45,000 children. Did my chairperson bother that I read at 5 centimeters distance? Doesn't matter, as long as we have trained the person to do so. And teachers would not like to have their child look at their reading material close. So one letter from you saying it is okay for this child to allow the reading material to be held close, fine, the teacher's anxiety will reduce because it's coming from a doctor. And do not forget the low vision devices, and which are both optical and non-optical, and also glare controlling devices, because there's a lot of glare that children experience that needs to be looked into if we want to improve the quality of life and also make reading, writing enjoyable for children. And as I said, there's a lot of work that you need to do in terms of counseling. If I am where I am, it is my pediatric ophthalmologist who gave that courage to my parents, saying that she'll be fine, it's okay. So it's you who are the person who can counsel. Your 2 sentences makes a lot of difference in getting the child to a mainstream school and not to a special school. And a lot of emphasis on environmental changing, play, and all of it. So don't look at that thank you slide, because I'm not going to stop. I'm going to just continue with the next part, which is the quality of life.
Have 4 minutes.
Yeah, quality of life. So we all know the quality of life is impacted because of so many difficulties that the person is facing. These problems are just not going to be limited to just near vision activities or reading activities, but also because their distance and near vision is impacted. Use of devices, gadgets, computers are also impacted. When the child goes to school, you would see here is a low vision child who is still writing, while you see the rest of the kids have finished their work, they are enjoying themselves, they are having beautiful conversation. There is a lot that needs to be done in terms of support for the child in classroom, including say a telescope, okay. But in the classroom, there is a lot of advocacy that you need to do. For example, allowing the teacher to give methods to how she can use work devices that allow the child to take it closely and see. And the kind of modifications that you can suggest in terms of felt pens, an Apsara pencil instead of the usual pencil, and other writing reading materials are going to make a lot of difference. We talked about visual crowding. There is a small non-optical device called as a typoscope, which is very useful to reduce crowding. But because it's a non-optical device, it sometimes remains out of our memory. Contrast plays a very important role, both in contrast in terms of the digital equipment that we use and also in the household material. This is just a chopping board. All you need to do is tell the parent, for example, to paint the other half of the chopping board in a dark color. You must be thinking, why is she talking about chopping board? Because I expect a child with visual impairment to grow up, cook, and also do the household chores. Okay, so accessibility is a very important aspect, and we as service providers needs to ensure that your clinical setting, the product, the service that you provide, and the building that you provide, is it accessible, is it colorful? These are small modifications that you can make by painting just the rim of the wash basin with a contrast color, having wash basins and wash areas in contrast. There is a lot of work that can be done as advocates for having bus numbers that are visible. When I was in Delhi and there was Commonwealth Games, we worked on making the buses accessible and the railway stations accessible. These are tactile tiles you are all familiar with, because you see the yellow tile in the railway station, but also remember there are other contrast tiles, and when you put it in a square pattern like this, it indicates to the visually impaired person that this is a corner and there is a possibility. If you are in large institutions, ensure that you have zebra corners so that it is easy for the person to navigate and know left, right. We saw that compromisation of direction, laterality happens. And ramps and staircases, you need to have uniform lighting. Often the front part of the staircase is well lit, the back is dark, for example, so ensure that lightings are good. These are some examples of both how ramp, railing and staircases have to be there, and when the stairs are there, just ensure that you paint it with a contrast. And with that, I end both my presentations. Of course, I went through very fast, but I hope the message is loud and clear.